afternoon. I'm Julie Dees, Director of Behavioral Health at Penn Presbyterian, and I'm here to share with you the incredible work we've been doing to address the opioid crisis in Philadelphia. Let me introduce you to Nicole. She's a 35-year-old woman who's been struggling with heroin use on and off since she was 19. Because of this, she lost custody of her two young daughters, but she's determined to recover so she can get her kids back. But one day, she had a reoccurrence of use. She's found unresponsive on the trolley. EMS arrives, administers Narcan, and takes her to the Presby ED. When she's stable, she's discharged with information about the risk of heroin and given a phone number for a local rehab. Her aftercare instructions simply said, "Please stop abusing these multiple drugs. It will lead to your death." Laura's addiction is a medical condition, but the treatment she received failed to address it. Fighting addiction is an uphill battle, and yet Laura left the ED alone and without a plan. We must do better. Philadelphia has by far the highest opioid overdose death rate of any major city. We're Penn Medicine. Philadelphia's health problems are our health problems. There are about 2,100 yearly visits from patients with opioid use disorder, or OUD, in our 3 central EDs. That patients pass through without evidence-based treatment represents a catastrophic failure. We must do better. Treating substance use isn't easy. Historically, rehab and detox were the standard treatment, but success rate is 5 to 10% at best. But there is good news. Medications like buprenorphine and methadone are 60 to 80% effective. Buprenorphine, or bup for short, is unique in that regulations allow it to be prescribed and administered in the ED. We got more good news. We got these guys. Presby offers bedside counseling from certified recovery specialists, or CRSs, as well as outpatient substance use treatment. When we started this work, about 175 OUD patients visited the Presby ED each month. 10 of those were started on bup, and only 4 received a consult from a CRS. Why were these resources so underutilized? We identified some key barriers. First, patients must be identified. Many ED visits from OUD patients present for reasons that don't seem related to substance use. This makes them very difficult to identify. Additionally, many providers simply weren't aware of Penn's substance use services. And we were counting on the providers to call us, which is both time-consuming and easy to forget. Second, patients must be offered evidence-based treatment. Not every OUD patient can or wants to start on bup in the ED, but more importantly, there were only a handful of providers that were trained in using bup. Third, patients must have access to continued treatment. Physicians were hesitant to start patients on bup because they didn't know how or where patients would continue treatment post-discharge. Additionally, few doctors had their X waiver, which is the training required to write a script that would allow patients to remain on bup until their next appointment. You can imagine this like a funnel with drop-offs at each barrier. We set out to address these drop-offs, beginning with identification. We started by manually reviewing the Presby ED board and notifying our recovery specialists when we found a patient likely to have OUD. Truth be told, we struggled to predict which patients needed their support, but we were successfully identifying more patients, and the recovery specialists were able to take action. But this high-touch model wasn't scalable, so we developed an automated system to monitor the ED and automatically alert our team of likely OUD patients. Over time, and with many, many, many revisions, we got better at predicting which of these patients needed our support. This system helped us rapidly scale our intervention to HUP and PENC. We've gone from identifying only 6 patients per month to over 100. We've learned that patients with limited chart information can't be easily identified, so we wondered, would these otherwise unknown patients be willing to self-identify? So we tested this by creating these posters and putting them up around the Presby ED. We asked patients to call us if they felt like they would need to talk about this. And to our surprise, the very first week, someone called, and many calls have come in since then. And as an aside, the Surgeon General happened to post this very picture on his Twitter feed. I would encourage you to look at it. Not to brag. Building on this, we piloted a screening question in the ED. When asked if they'd used illicit drugs in the past 12 months, 1% of patients said yes to opioid use, but had no evidence of it in their chart. At scale, this question could identify over 1,400 patients each year that otherwise would have been missed, and that's just in the ED. Next, we focused on ensuring patients received evidence-based medication treatment in the ED. Dr. Perrone led a campaign using incentives to dramatically increase the percentage of ex-waivered ED faculty. We used social norming strategies like public messages and pins to celebrate and encourage the use of bupe as a first-line treatment. And to account for the difficulties our patients face staying in touch, we turned to a low-tech but appropriate solution. We provided patients wristbands, like the ones at your seat, with our contact information so they could reach us when they needed support. Let's look at how far we've come. Bupe use is increasing. More importantly, a greater share of eligible patients are starting on bupe in the ED, more than triple from where we started. Our recovery specialists are increasingly involved in ED care. And look, we have already expanded to all 3 of our downtown hospitals. We're reducing ED visits. Patients consulted by a CRS in the emergency department were significantly less likely to come back to the ED within 30 days of discharge. And this slide makes me smile every time. When there were very few patients that presented to the ED that were ever asked about substance use, given any sort of treatment options, or certainly enrolled in any sort of treatment options. But now, when patients receive both a CRS consult and are started on bupe, 68% not only start treatment, but are engaged in treatment at 30 days. That is remarkable. At our current rate of bupe use, we will prevent an estimated 187 overdoses each year. This work is transformative. We're changing lives, we're saving lives, and we're just getting started. Think back to Laura. Before our work began, she left the ED feeling judged, without treatment, and without support. Imagine she overdoses again and ends up back in our ED. This time, the system we developed automatically identifies that Laura is there and automatically notifies Nicole, our CRS, that she's in the ED. Nicole can go and speak to Laura bedside. They discuss Laura's treatment goals and her options. She says she's determined to get her kids back and she's ready to try bupe. Her physician gets her started, Nicole schedules a follow-up appointment at a Penn clinic, and Laura's given a bridge script so she can continue taking her medication until that follow-up appointment. This time, Laura leaves the ED on the right path. She has a plan, she has evidence-based treatment, and she has a peer to support her along the way. That, in a nutshell, is CORE. We're ready to take this to the next step and expand CORE into the hospital, which we see as a natural extension of the work in the ED. In speaking with inpatient care teams, we believe a CORE-led addiction medicine consultation service will result in improved outcomes, shorter lengths of stay, and reduced readmissions. We will be piloting this service in Presby starting in May. This is our city. We're in crisis, but we've shown you a way forward. With your support, we can continue to build on this critical work. Thank you.